Hello everyone, welcome back to the channel essential of acute, emergency, and critical care. Today we'll discuss one of the most common electrolyte disorders encountered in emergency medicine, internal medicine, and intensive care, hyponatremia. Although it may appear simple because serum sodium is low, the real challenge lies in identifying the underlying cause and treating it safely. Overly rapid correction can be as dangerous as hyponatremia itself, leading to osmotic demyelination syndrome. By the end of this video, you'll be able to understand the pathophysiology of hyponatremia, diagnose the underlying cause using a stepwise algorithm, interpret urine sodium and urine osmolality, know when hypertonic saline is indicated, and avoid common management mistakes. Let's begin. Hyponatremia is defined as serum sodium less than 135 millimoles per liter. Remember, hyponatremia is primarily a disorder of water balance, not sodium deficiency. The plasma sodium concentration depends on the ratio between total body sodium and total body water. Most patients become hyponatremic because of excess water retention, impaired water excretion, and increased ADH secretion, rather than actual sodium loss. The kidney normally excretes large amounts of free water. Whenever ADH is elevated, water is retained, diluting plasma sodium. So the key question is not, why is sodium low? Instead ask, why is water high? Symptoms depend on severity of hyponatremia and speed of onset of hyponatremia. Mild hyponatremia is defined as serum sodium 130 to 135. Often asymptomatic, may present with fatigue, gait instability, and mild confusion. Moderate hyponatremia is serum sodium 125 to 129 milliequivalent per liter. Symptoms may include headache, nausea, vomiting, dizziness, and cognitive dysfunction. Severe hyponatremia if sodium is less than 120. It may present as seizures, coma, respiratory arrest, and brain herniation. Acute hyponatremia developing within 48 hours is much more dangerous than chronic hyponatremia because the brain has not yet adapted. Here is a practical 5-step approach. Number 1 step. Confirm true hyponatremia. Measure serum osmolality. 3 possibilities exist. Possibility first. Hypertonic hyponatremia. High serum osmolality occurs due to osmotic substances like hyperglycemia and mannitol. Water shifts from cells into extracellular fluid, diluting sodium. Remember, correct sodium for hyperglycemia, approximately, as sodium falls due to dilution. While adding correction, sodium increases by 1.6 to 2.4 millimoles per liter for every 100 milligrams per deciliter increase in glucose above normal. Second possibility is isotonic hyponatremia, also called pseudohyponatremia. Occurs with severe hypertriglyceridemia and hyperproteinemia such as multiple myeloma. Measured sodium appears low but plasma tonicity is normal. Third possibility, hypotonic hyponatremia. This accounts for over 90% of patients. Step 2. Measure urine osmolality. This tells us whether ADH is active. Urine osmolality below 100 milliosmol per kg means in the setting of hyponatremia. ADH is appropriately suppressed and kidneys are trying to eliminate excess water. Causes include primary polydipsia, Pathophysiology, tea and toast syndrome, and low solute intake. But when urine osmolality is above 100, it means ADH is active. So, now determine why. Step 3. Assess volume status. Classify the patient into number 1. Hypovolemic. That means loss of both sodium and water. Examples: vomiting, diarrhea, diuretics, and adrenal insufficiency. Number 2. Euvolemic. Normal extracellular volume. Common causes: syndrome of inappropriate antidiuretic hormone, hypothyroidism, glucocorticoid deficiency, and drugs such as SSRIs and carbamazepine. Number 3. Hypervolemic. Water retention exceeds sodium retention. Examples: heart failure, cirrhosis, nephrotic syndrome, and advanced kidney failure. Step 4. Measure urine sodium. Urine sodium helps identify whether the kidney is conserving sodium. Urine sodium below 30 millimoles per liter suggests extrarenal sodium loss or decreased effective arterial blood volume. Examples: vomiting, diarrhea, heart failure, and cirrhosis. When urine sodium above 30 millimoles per liter suggests renal sodium loss or syndrome of inappropriate antidiuretic hormone. Examples: diuretics, adrenal insufficiency, salt-wasting nephropathy, or syndrome of inappropriate antidiuretic hormone. Last and step 5. Exclude endocrine disorders. Before diagnosing syndrome of inappropriate antidiuretic hormone secretion, check thyroid function and morning cortisol. Syndrome of inappropriate antidiuretic hormone is the most common euvolemic cause of hyponatremia. It is characterized by euvolemic hypotonic hyponatremia, urine osmolality above 100, urine sodium above 30, normal renal function, normal thyroid function, and normal adrenal functions. Common causes include pneumonia, CNS disorders, malignancy, especially small cell lung cancer, medications including SSRIs, carbamazepine, cyclophosphamide. Treatment includes fluid restriction, increased solute intake, oral urea where available, loop diuretics in selected patients, and vasopressin antagonists in carefully selected cases. Treatment depends on symptoms, not simply sodium level. Severe symptomatic hyponatremia. Examples: presence of seizures, coma, and severe confusion. Treat immediately with 3% hypertonic saline. Current international guidelines recommend 100 to 150 milliliters bolus over 10 to 20 minutes. Repeat if symptoms persist. Increase serum sodium by 4 to 6 millimoles per liter initially, which is usually sufficient to reduce cerebral edema. For chronic or mild hyponatremia, treat the underlying cause. Examples: hypovolemia, normal saline, syndrome of inappropriate antidiuretic hormone, fluid restriction, heart failure, fluid and sodium restriction with diuretics, adrenal insufficiency, steroid replacement, Hypothyroidism, thyroxine replacement. Avoid overcorrection. Maximum correction, generally, no more than 8 millimoles per liter in 24 hours. Patients at high risk for osmotic demyelination, including alcoholism, malnutrition, liver disease, hypokalemia, and very severe chronic hyponatremia, should have even more conservative correction targets, often 4 to 6 millimoles per liter in 24 hours. Monitor sodium every 2 to 4 hours during active treatment. To summarize, hyponatremia is usually a disorder of excess water, not sodium deficiency. A systematic approach using serum osmolality, urine osmolality, volume status, and urine sodium will correctly identify the cause of hyponatremia in the vast majority of patients. Remember, successful management depends not only on correcting sodium but also on correcting the underlying disorder while avoiding complications such as osmotic demyelination. If you found this video helpful, please like, subscribe, and share it with your colleagues. Thank you for watching.